Thanks again. I always enjoy this these talks that they have very nice, fancy titles that allows you to say whatever you think. And so I take the liberty to go on with my case, which have been devoted during the last few years, that I'm trying to make my fellow cardiologists not to feel guilty for everything that happened in this country. There are other people that they participated much harder and they worked much harder against this country, and we don't have to feel guilty. And that's what is my mission nowadays. Let's go a bit further, and I'll try to give you, tell you a few things. I'll try to give you very simple lessons of economics. There's no move, for some reason. It's not only my glasses, but also there's no... Okay. So I'll try to give you a few simple lessons of health economics, and I'll try to make you understand where we're going into by all these managers that they try to control every single part of our life. And everyone talks nowadays about QALYs. QALY, that it's not the QALY. What is QALY? QALY is quality adjusted life year, and it is a health economic term which allows you to quantify the health effect of any medical intervention, and in the end, help the health payers to allocate healthcare resources. So then this way they will decide where they are going to spend the money. And how is calculated? It's calculated if we assume that with a new device or a new drug or whatever medical intervention, we have 1 year of life in perfect health, and perfect health, and the perfect health takes 1, and when you are dying it gets 0. Then if you have 1 year of life in perfect health, that means 1 QALY. If you have 1 year of life but in half-sort sort of health, that gets 0.5 of QALY. So that's what is QALY, and that's estimated. And take a few more examples. For example, if a person with a disease lives, with the current standard treatment, lives 3 years in a lifestyle of 0.7, that this current treatment gives him 2.1 QALYs. A new medication comes in, and that does not increase the expectancy of life, but it increases the quality of life from 0.7 to 0.9. And who defines what 0.7, 0.9 is? That's another thing. That gives him 2.7 QALYs. So the new intervention adds 0.6 QALYs. And not only this, but with using this type of technique, we can compare the health effect of any sort of treatment, different treatments. For example, anti-cancer treatment versus TAVI. And we can say how much QALY we gain with TAVI and how much we get with this anti-cancer treatment. And then is the cost of TAVI, the cost of QALY. That's what is the important thing. How much this QALY costs. And see how this is calculated. For example, with a new drug, we will live 5 years with quality of life of 0.7. That gives QALYs 3.5, 5 plus 0.7. With the standard therapy, we live only 1 year with a quality of life of 0.3. The old QALY was 0.3. So what we gained is 3.2. And in what cost? The life expectancy of 5 years costs 5,000 per year, because that is a medication. So it's 25,000. The current treatment costs 1,000, but only for 1 year, because after 1 year we'll die. That means 24,000 extra money. 24,000. If we divide with 3.2, that gives a 7,500 cost per QALY. That is the cost QALY, and that's how it's calculated. Let's go a bit further down. It's not only QALY, it's ICER. What is ICER? Incremental cost-effectiveness ratio, another way of another statistic. This the other way around. Now we've got the cost and we've got the effect. Before we had the effect and then we had the cost. And so we defined the cost to the effect is the alternative, the other way around, the alternative of the quality, the cost per quality. And this is the ICE. And in the end, how much the health system should pay per quality? That's the big decision. And there's no standard way for that. I can tell you about the British standards and how they evolved. In 2004, the British decided that the health system can afford to pay 20,000 to 30,000 per quality, pounds, 20 to 30,000 pounds per quality. In 2009, they accepted that when we speak about end-of-life treatments, for example, somebody who's had cancer and is going to live only 6 months, then okay, we can pay for these anti-cancer drugs up to 50,000 per quality. And in 2016, they accepted for orphan drugs, we can pay up to 100 per quality, but we have to bear in mind that it will not cost to the whole system more than 20 million per year for the first 3 fiscal years following launch. And if it's more than that, then the government has to go to a commercial agreement with the company. And here you can see the different qualities in Britain, how much they are. For example, the cost of the GP advice to stop smoking is 270 qualities. The bypass surgery is here, is 18,000 cost per quality. The heart transplantation, it's much cheaper. It's less than 6,000 per quality. Erythropoietin for treating anemia in dialysis patient is 55,000 per quality. Now, let's see now how, and then we have another question. Okay, that's good for the British, that's their standards, this is how they decide. How should a country like Zimbabwe or Greece should decide? Because we are poorer. We are poorer than Britain, and Zimbabwe is poorer than Greece. So how we should decide? And the managers, they have all the financial people, they have 3 ways of deciding for the different countries. One is for the capital gross domestic product. As we can say in Greece, katakefali εισόδημα. And they say to be accepted and to be well, that's the cost per quality should not be bigger than 3 times the capital gross domestic product, the GDP. If we say for Greece that we've got about 15,000 or 20,000, I don't know how much we've got, the GDP, then up to 50,000. That's another threshold. This is for the Americans. The Americans, they say that there are certain treatments that it's must. For example, dialysis. What is the cost for dialysis per quality? 50,000. So this is what is allowed to pay. And there's another way, which is used for 3 world countries, which say, how much money can we spend? This is the amount of money. Put the ICEs now, make a list of the ICEs. 1, 2, 3, 4. And when the money finishes, then you stop. The others are not allowed. That's the ways that we can decide. I don't know if you like that, but this is what is the way of things they are trying to make them. So let's speak now 1 slide about TAVI in Greece and Qualis. Because we're speaking about very much about cost, how much is worthy treating people that they're 80, they're 85, or that's whatever the age they are. First of all, we have to have an open and discussion about what our societal ethics should be. What do we like? Do we accept this way of thresholds? Do we like them? Is that the society that we like? Let's decide. Then we have to estimate our own QALYs. The QALYs are different, because I'm seeing different trials about QALYs, about TAVI, about this, about the other, but they're different things. For example, if you take the QALY for TAVI, depends upon the cost of the valve, the cost of the hospital care, the salary of the doctor, the salary of the nurse. It's different. If you take the QALY, if the American QALY is much bigger because the doctor is paid much more and is paid per case, when in Greece is paid a salary, especially in the NHS. And it doesn't mean how many TAVIs will implant, his salary will remain the same. And then negotiate the cost. We have to decide how much we're going to pay and then to make good negotiations and not allowing everyone to buy independently and leave the market to lead us. We have as society to lead the need, to lead the markets, and not the markets and the industry lead the society. And then decide which of one of the previous thresholds we'd like to implement. Would like the American way, 50,000, what is the dialysis? Estimate the cost of dialysis and say this is the cost for every QALY that we're going to pay. Would like the British one, which is a bit different? Say, for example, this 40,000 pounds, which is similar to 50,000 euros, for everything except for anti-cancer, which can go up, and for the orphan drugs, which can go up to 1,000 for orphan drugs. That's another way. Would you like this GDP way that says that multiply plus 3 and whatever is above, below 3, it's okay. Whatever is above 3, just stop it. And you are not allowed, and only one who is rich enough can pay out of his own pocket can get it? Or would you like the one which makes the league? And this is the money, here we are, we spend it all, we can finish now. And with this, I would like to invite you to the course in Yanina, which is going to be the cardio cath, and I hope you will enjoy there again an interventional course with lots